Chapter 27, chest and abdominal trauma. This is kind of a short section, short chapter. There's some really important things in here. We'll drill down on the most important things in here, but please, please, please make sure you guys are reading through your books because there's a lot more than we can provide you, okay? We'll talk about chest injuries and abdominal injuries. Let's start with chest injuries. Okay, a couple different types of trauma you might see in the chest. Talk about blunt trauma, blunt force trauma. Can fracture the ribs, sternum, and the rib cartilages. All right, and then that can actually cause compression. When a severe blunt trauma causes the chest to rapidly compress. All right, we could have penetrating objects, bullets, knives, pieces of metal or glass, steel rods, pipes, other objects, and can damage the internal organs and impair respiration. All right, so closed chest injuries. This is a term that you will absolutely see on your test, guarantee it, and it's something you guys really, really need to understand. It's paradoxical motion, flail chest, okay? Flail chest occurs when blunt trauma creates a fracture of 2 or more ribs in 2 or more places. So if you're asked a question that says, what defines flail chest? Okay, you're looking, you're going to answer that question by saying it's a fracture of 2 or more ribs in 2 or more places, and there is a paradoxical motion. And we'll look at the picture of what we mean by that here in a second. Okay, this picture here pretty much just defines what a paradoxical motion is. All right, so on inspiration, the chest cavity gets bigger, but that flail section, the broken section, will actually go in. Okay, now when you breathe out, your chest cavity shrinks, gets smaller, but that flail section will move out. Okay, so now when you're palpating someone's ribs and they're breathing in, they're breathing out, and you feel a chunk of rib going in the opposite direction, that's paradoxical motion. Okay, you guys have to know what that is. Okay, defined flail chest, again, fractured in 2 or more consecutive ribs in 2 or more places. All right, and the paradoxical motion, movement of flail segment is opposite to the movement of the remainder of the chest cavities. All right, so how do we assess people with a potential chest injury? We want to look at the mechanism of injury. Okay, what happened to that person to make you suspect this could be a chest injury? Somebody gets smashed in the chest with a baseball bat. Did they fall from really far? Were they in a bad car accident? Okay, these are all things that we're put our detective hats on and try to figure out what type of injury this person could be having. Are they having difficulty breathing? Are they hypoxic? Okay, pain, obviously, likely signs of shock and hypoxia, and chest wall muscle contraction. Okay, we want to do our primary assessment for life threats. You guys have had primary assessment. I know you've gone through it a little bit. All right, remember in that first block, that first most important thing in the primary assessment is how we identify life-threatening injuries or illnesses. Those are our ABCs, okay? Administer oxygen if necessary. If the patient's breathing inadequately, and we've talked about adequate respiration and how to bag valve and all that, okay, we're going to assist them. Local protocols regarding non-invasive positive pressure ventilations. Our protocols allow us to bag patients. That's all this is referring to. Okay, watch the patient carefully and watch the respiration rate and depth. If there's any changes, if it gets shallow, if it gets faster, those are all indicators that something more serious is going on, okay? Open chest injuries. Difficult to tell what's injured from an entrance wound, right? Assume all wounds are life-threatening. Open wounds allow air into the chest. It sets an imbalance of pressure and causes the lungs to collapse. We'll show a picture and we'll explain exactly what we mean by that. Okay, but there is a pressure balance inside your chest cavity, and if you break that, if you puncture that, and the outside air gets into the chest, it's throwing off the pressure balance change. The pressure balance between the chest and the outside air, and it can cause the lungs to collapse. Okay, but what we'll see is what's described, defined, called a sucking chest wound. Whoops, excuse me. Sorry about that. All right, a sucking chest wound, you can actually hear the air sucking out of the chest or into the chest cavity, okay? That means that the chest cavity is open to the atmosphere. There may or may not be a sucking sound, so just because you see a hole in someone's chest and it's not making a sucking sound, doesn't mean that this is not a sucking chest wound, okay? They may be gasping for air. Okay, we want to maintain an open airway always. Seal the wound. Apply an occlusive dressing, which we'll show you pictures of here in a second. Administer oxygen, care for shock, immediate transport, consider ALS. Don't consider ALS. ALS needs to be called. This is an ALS call, 100%. Anything that has to do with A, B, or C being out of whack basically makes it an ALS call. Okay. We will talk about the occlusive and occlusive dressings. Okay, they involve taping and a dressing in place and leaving a side or a corner of the dressing unsealed. Again, we'll see a picture here in a second so you guys can understand what we're talking about. As the patient inhales, the dressing will seal the wound. As the patient exhales, okay, that little flap that you made, that third side that you left untaped, that lets any air out of the chest cavity. It's like a one-way valve, okay? And here's a picture right here. So when this person's breathing in, it's not letting any more atmospheric air into the chest cavity, okay? Now, when they breathe out, any air that is inside the chest cavity that already got in will be expelled, okay? They make commercial devices, commercial occlusive dressings. They come in a little package. It's like a one-way valve on there. We have a couple in class that we can show you. You peel the tape off the backside, stick it onto their chest, and it does everything for you. You can make one of these out of any piece of plastic. We carry saran wrap on our ambulance that meets Part 800, and just take it and tape it down on 3 sides. Okay, injuries within the chest cavity. So we have our pneumothorax. That should say hemothorax. Oh, I should say tension. Excuse me. The slide is kind of messed up. I apologize. The top line here should say pneumothorax and tension pneumothorax. And then so we have the pneumothorax. Again, think to your medical terminology. Okay, pneumo is air. Okay, hemothorax and hemopneumothorax. Okay, hemo being blood. Hemopneumo means blood and air. Okay, traumatic asphyxia. We have cardiac tamponade and aortic injuries and dissections. We can talk about that. I know we'll talk about that more when we get to the abdominal injury section, what the aortic injury and that is. But yeah, we'll talk about all 4 of those things. Okay, pneumothorax. Pneumothorax is when air enters the chest cavity, possibly causing lung collapse. Again, you puncture that chest wall, whether it be a bullet or a knife, or I actually had somebody start to have a pneumothorax because they got stabbed with a key. Man and wife were fighting with each other. She stabbed him with a key, like a house key, and it was just enough to get in between the ribs and puncture that. And he started to actually get some air inside his chest cavity. That's not a major thing right now, but as the more air that gets inside his chest cavity, the worse and worse it's going to get. So it's actually relatively easy to get a pneumothorax if you puncture that chest cavity. So we have our pneumothorax is where the air gets in the chest cavity, and our tension pneumothorax is a type of pneumothorax where air that enters the chest cavity is prevented from escaping. So basically the air is building up inside the chest cavity. The pneumothorax is when the air goes into the chest cavity. The tension pneumothorax is when the pressure starts to build up inside the chest cavity, and now it's collapsing lungs and it's causing damage. Okay. Air can enter the chest cavity through a puncture in the chest wall, and this can cause a collapse of a lung and impaired breathing. Again, this picture right here where the arrow is, it shows that they have a hole in the chest wall. Atmospheric air is getting into the chest cavity. This is the chest cavity, and this is the lung itself, all right, that is collapsing because of that pressure change. okay? These patients will typically have diminished or absent lung sounds on the affected side. So when we do our lung sounds, it's very important to try to distinguish left from right. And anybody with this type of chest injury, we better be getting lung sounds, okay? Hemothorax is when the chest cavity is filling up with blood for whatever reason. Something's damaged inside the chest cavity, and now it's starting to fill up with blood, and that can collapse the lung. And then a hemopneumo is when it's filling with blood and air. And here's a nice picture of that. The pneumothorax on the left. Okay. Hemothorax on the middle, and then a hemopneumo on the right. So it's filling up with blood and air. Okay, traumatic asphyxia. It's one of those terms we talked about here a second ago. All right, it's the sudden compression of the chest forcing blood out of organs and rupturing blood vessels. Neck and the face are darker color than the rest of the body. May cause bulging eyes, distended neck veins, and broken blood vessels in the face. Okay, so think a car, somebody's underneath the car working on it, and the jack kicks out and it crushes them in the chest. That's what this is referring to. Okay, and then cardiac tamponade. Tamponade, I'm not really sure how to pronounce that, but either way. So it's a direct injury to the heart, causing blood to flow into the pericardial sac around the heart. The pericardium is a tough sac that rarely leaks, but the increased pressure on the heart increases pressure on the heart so the chambers cannot fill. Don't know if there's a picture. Let me go back to this one here, if you guys can see my mouse cursor here. So the heart is sitting in the pericardial sac. So it's just like a layer of skin, tissue around the heart. And if that gets punctured, the blood actually leaks inside between the heart and the pericardial sac. Okay, it's not necessarily leaking out into the chest cavity, but it's actually squeezing. And as that blood fills up the pericardial sac, it puts pressure on the heart, and it makes the heart harder and harder for it to pump. Okay, and that's what we're talking about with cardiac tamponade. Okay, so again, increased pressure on the heart so the chambers cannot fill. The blood backs up into the veins, usually a result of a penetrating trauma. So something poked somebody in the chest. Maybe it didn't go through their heart, but it was enough to poke that sac. Okay, you will see distended neck veins, which is part of our assessment, right? We're looking for jugular vein distension. And shock and narrowed pulse pressure. Okay, so you're going to show shock-like symptoms. Okay, aortic injury and dissection. The aorta is the largest blood vessel in the body. Penetrating trauma can cause direct damage. Blunt trauma can sever or tear the aorta. Damage can cause high-pressure bleeding, often fatal. So the aorta, I'm just going to skip ahead just real quick because I'm looking for, okay, I'm going to go back to the heart picture again. All right, so you see these, see this red thing right here that my mouse is on, coming out of the top of the heart? That's the aorta. That's the aortic arch. It is a huge blood vessel, and that distributes all the blood to the body. So when it comes out of the heart, it's big, and it gets smaller throughout the arteries of the body, but even down through your abdominal aorta, which is down in behind your guts, I guess, in your stomach. That is a huge blood vessel, okay? And when we're talking about the dissection, if something happens where the aorta tears off the heart, there is nothing we can do for that patient but hurry to the hospital. This person is dumping a lot of blood into the chest cavity incredibly quickly. They're probably not going to survive. Okay, this is very, very, very serious, and that can happen with severe, severe trauma, car accidents, and that. All right. So yeah, the damage can cause high pressure bleeding, often fatal. Patient complains of pain in the chest, abdomen, or back. They're showing signs of shock, and maybe you're like, man, what's going on with this person? I can't. There's nothing obvious. I can't see anything. It's all going on inside their chest cavity. Could be differences in pulse or blood pressure between the right and left arms. Okay, their whole circulatory system is messed up right now. All right, so if you see any of these signs, you can absolutely start to, well, we're not going to diagnose it, but we're going to suspect an aortic dissection, and we need to really get to the hospital very quickly and give a good med report so they know what they got coming in. Okay, commotio cordis. This is kind of a weird thing that can happen. There is one part in your heart rhythm. If we look at a regular strip, heart rhythm strip, if you get hit in the chest at just the perfect time, it can actually put you into ventricular fibrillation. It's essentially giving you a heart attack. Your heart stops. It's a weird thing. You hear about it occasionally, like in football games, because a person gets hit, and it just happens to be at that perfect millisecond. And they get hit in the chest just right, and it can cause this condition called commotio cordis. You'll be responding to like an unresponsive person that may have gotten some type of hit by something. All right, here's an open pneumothorax and hemothorax animation. Take a quick look at this. Oh, media not found. That's all right. Again, like I told you guys in some of the other presentations, YouTube has a lot of these videos out there. Probably a lot better quality. All right, abdominal injuries. Okay, they can be open or closed. Internal bleeding can be severe if organs or blood vessels are lacerated or ruptured. Okay, serious painful reactions if the hollow organs rupture. Evisceration may occur. What do you mean the organs? I didn't. Siri. Shh. Sorry, guys. Evisceration may occur. Organs protruding through the wound opening. There's a picture of an evisceration with some organs sticking out. Of course, this isn't a real photo, so don't get too excited. First, take standard precautions. Cover and dress the wound to maintain warmth. Secure the covering with tape or cravats tied above and below the position of the exposed organ. So we're not going to shove our organs back in. Okay, we want to keep them warm. Get them covered up with some sterile dressings. All right, patient assessment. So this is abdominal injury. How are we going to assess these people? Okay. All right, pain might be initially mild, but rapidly becoming intolerable. They could have cramps, they could have nausea, they could have weakness, they could be really thirsty. Then there could be obvious lacerations. Okay, lacerations and punctures, wounds to the pelvis and middle of lower back. So any of those areas we see any major lacerations or punctures, we need to be suspecting some kind of internal trauma, internal damage. Indications of blunt trauma, indications of developing shock. Again, we talk about shock an awful lot around here. We will drill on it in every single section. Please know the signs and symptoms of shock. I was talking to some people who have recently taken the state test. There is a lot of questions regarding shock on that new test. So please really take the shock questions seriously. All right, coughing up blood, rigid or tender abdomen, distended abdomen, patient tries the lie very still. Stay alert for vomiting. So what do we need to worry about with vomiting? Is airway issues, right? So suction. Place the patient on their back with legs flexed at the knees to reduce tension on the abdomen muscles. Administer oxygen if necessary. Care for shock. Don't give them anything to eat or drink. Again, if they're thirsty, like was one of the signs and symptoms back there, we don't want to give them anything to eat or drink. Continuously monitor vital signs and transport as soon as possible. All right, additional steps for open abdominal injuries. Control any external bleeding, address all the wounds. Do not touch or replace eviscerated organs. Like I said, we don't shove the organs back in. Okay, apply sterile dressing moistened with sterile saline over the wound site. Do not touch or replace the eviscerated organs. For a large evisceration, maintain warmth by placing layers of bulky dressing over an occlusive dressing. All right, that's if you got a lot of gut spilling out. Put a big bulky dressing on there. Okay. If there's any impalement, again, when we talked about this in another section, we don't remove impaled objects unless it's in the cheek, and we can get to both sides to control bleeding. If they're impaled with something through their abdomen, we're not going to remove that item. So hopefully it's not too big where we got to get a piece cut off to get them in the ambulance. Occasionally you'll see that in the, Chicago Fire, those TV shows, you'll see things like that happen. I've never seen it. I know it does happen. It's a very rare thing. But just remember that we don't pull those things out. Stabilize with bulky dressings. Leave the patient's legs in position found to avoid muscular movement that may move the impaled object. We don't want that person to be moving around a whole lot. If they're writhing in pain and they're kicking their legs around, they're probably doing more damage internally. All right, let's see if this one works. Nope, media not found. Okay. Liver injuries. Again, that's something for you guys to take a look at on YouTube. The liver injury, the chest injury, and the abdominal injury. All right, quick chapter review. We'll just hit on a couple of these points. An open chest wound or abdominal wound is considered to be one that penetrates not only the skin, but the chest and abdominal wall to expose internal organs. Open chests and abdominal wounds are life-threatening. For an open chest or abdominal wound, apply an occlusive dressing. This will be a test question, I promise you, referring to the sucking chest wound. If you have a patient and they have a chest wound and you hear a sucking sound, what do you do first? Okay, it's one of those questions where all the answers are probably right in things that you're going to do, but what do you do first? And the answer to that is you place your gloved hand over the hole. It's very important to stop the air from going in the chest very quickly. Now, while your hand is on their chest, your gloved hand is on their chest holding that seal, you with your other hand or your partner is getting an occlusive dressing ready. Okay, we're not going to let air get into that person's chest while we're preparing this occlusive dressing. You placed your gloved hand on there. That will be a test question, I promise you. Okay, for both open and closed injuries, take appropriate standard precautions. Note the mechanism of injury. Protect the patient's airway and breathing. Administer oxygen if necessary. Treat for shock and transport. Flail chest, you need to know this definition, is characterized by paradoxical motion. Okay, that's 2 or more ribs in 2 or more places, and that section of broken rib is moving in the opposite direction than the rest of the chest. That is what a flail chest is. If the patient's unable to adequately breathe, assist the patient's ventilations. Sorry about the noise. Sorry about the noise, guys. I am doing this at work, so occasionally there's some tones in the background. I paused it there for a sec. All right. We seal an open chest wound with an occlusive dressing taped on 3 sides or in some other manner so that it acts as a one-way valve, allowing air out of the chest but not in. Alternatively, use a commercial device such as an Asherman chest seal with a one-way valve to relieve pressure. That Asherman chest seal is one of those commercial devices that I was referring to earlier. It's already got a one-way valve set in it, and you peel the tape off, you stick it on the chest, and you're good to go. But we do need to know how to make an occlusive dressing. So make sure you know, you understand what an occlusive dressing is and how to actually make one. Monitor the patient for changes. Be prepared to manually relieve any pressure of the chest. We as basics don't do any manual relieving of the pressure on the chest. Paramedics can do a needle decompression where they can put a needle into the chest and that'll relieve the pressure. That's something ALS, we don't need to really dig into that too much right now. Closed chest wounds are sometimes difficult to distinguish or may occur together. Assess the patient, including breath sounds, and maintain ventilation, oxygenation, and perfusion. Lung sounds are very, very important, okay? Most of our patients, and as far as everything in this class is concerned, any of the scenarios we give you, any of the testing scenarios we give you, you have to listen to lung sounds on every single patient. So get in the habit of doing so. All right. A patient who collapses in cardiac arrest after force to the center of the chest should receive CPR and defibrillation like any other arrest from a cardiac issue. That we're referring to the commotio cordis thing that's very rare that can happen. All right. If a patient develops signs of attention pneumothorax, arrange immediately for ALS intercept or transport promptly to a facility that can treat this injury. Okay. A quick note on ALS. Most of the dispatch is very good at screening these calls and sending the resources that are needed at the time the call comes in. So they'll automatically send a medic sometimes, okay? They do make mistakes and it's not their fault, but they don't know what's going on scene. So if this comes in as a BLS priority call, just for example, and you get there and you're like, oh crap, this is an ALS call. That's why it's important to identify what's going on early on in the scenario. Get those resources coming your way, and then you continue through your assessment. That way the medic's already coming. Now, if you don't have a medic coming, and it's faster for you to go to the hospital than it is to wait for a medic, let's just say hypothetically, the county medic, which you say your department relies on the county medic's on another call, and they have to call the medic from Sheridan down to Frewsburg for ALS, that's the closest medic, just go to the hospital. Don't wait for the medic to get on scene to transport. The nearest facility might be more appropriate than waiting for the paramedic to show up, okay? When solid abdominal organs are injured, life-threatening amounts of blood loss can occur. When hollow abdominal organs are injured, their contents spill into the abdominal cavity, causing irritation. So again, we have our hollow organs, we have our solid organs. The solid ones, you're going to bleed out very quickly. We're talking like kidneys, liver. Some of the hollow organs, you might be talking about like the intestines. If the intestines get punctured, they are hollow, and the contents of those hollow organs are going to spill out in the abdominal cavity and cause a lot of pain and infection, which I don't know what's better. You bleed out from the inside, or you get, digested food and bile and stuff into your abdominal cavity causing the infection. I'd say you'd probably be more likely to survive a hollow organ injury. But I don't know, either way, they're both very serious. Remember, the blunt trauma, penetrating trauma, and compression are mechanisms that can injure the chest and abdomen. Open or closed pertains to the integrity of the chest or the abdominal wall after injury. We know what open and closed wounds are now. All right. Seal open chest wounds to prevent air from entering the chest cavity. Closed chest and abdominal wounds bear a high risk for underlying organ system damage and internal bleeding. Use mechanism of injury and patient assessment to recognize the signs and symptoms of shock. Again, we have to know the signs and symptoms of shock. EMT should learn signs and symptoms and treatment procedures for specific chest and abdominal injuries. Here's some questions for you guys to consider. Is the patient's breathing adequate, inadequate, or absent? Again, that's why it's important for us to get lung sounds. Is the patient displaying signs of shock? The altered mental status, the low blood pressure, high heart rate, high respiration rate, clammy skin, okay? Is there an open wound in the chest that needs to be sealed? That needs to be taken care of immediately. Okay, is the patient displaying signs of attention pneumothorax? Is there an open wound in the abdomen that needs to be dressed and covered? Okay, a couple critical thinking questions. These questions are all in your book. And that is it for chapter 27. All right. I will see you guys.